It's nice to see you guys. Thank you for coming tonight. It's kind of a rainy night here, and we have a lot to talk about, and I'm very curious to hear perspectives, and it's just a pleasure to meet all of you. Some of you have gotten to know over the years too, from when this all started. I'm kind of a dinosaur from the past, but I'm excited to see you guys, and it's an interesting topic because there's a lot of moving parts actually in Colorado. So your perspective is really, really important. And the case studies themselves are interesting, but I think also some of the alternatives that we're looking at and how we're going to proceed or not, actually, depending on the circumstances. So, and if I don't respond to you in the chat log, just try to poke at me. Our internet's a little slow tonight because of the rain. It always happens. So I'm going to try to keep a good eye on that. And it looks like we have a variety of people from all over the place. Some names I recognize. Okay. Right. Okay. All right. So we're going to go ahead and get started. I'm going to go ahead and jump to the slide. And I just need to hear somebody unmute and say yes or no. They can see this.
I can see you.
How about, let me see if I can do this now. How about now?
Yeah, we can see the slide with the cow and the
Yeah. Okay.
EMS.
Hey, Kevin. How are you?
Hey, good. How are you guys?
Nice to see you. Okay, you guys should see the whole enchilada here in just a second. Okay. So when it's an interesting thing in Colorado. And a lot of you I recognize from some of the areas that I've worked in and some from um urban versus frontier versus, wilderness and what does that really mean? Well, actually, it's a lot of similar stuff, honestly. It's more of a mindset in how we approach things and how we have to think about things. And the other part of that is, and please share your perspective. How many of you are actually active in listening to the committees that are doing work on things like the Rural Blood Project, telemedicine, even IV access, and IV education for rural services? Are any of you listening or paying attention to those state committees that are meeting? Or even heard of them. Actually, the Blood Project would probably be one, the Blood Distribution Project is probably one of the bigger, more visible ones right now. Well, I will definitely share those resources with you. And the reason I bring it up is, and I'll be honest, I was born in a very rural area. When we define rural and frontier, Colorado has varying definitions of what that means and wilderness. I will say that in the mindset of all of this, it's more of, I think, being more proactive in thinking about what resources we have and what resources we don't have, and how am I going to deal with having something or not having something. So, a lot of you are saying you hear secondhand through critical hospital updates. Most of us are in critical access hospital areas. There's some very challenging things happening in EMS and frankly in healthcare as a whole for all of us, including hospitals. So whether you're on the Navajo reservation, I was fortunate enough to spend 4 years in Gallup and gain an entirely different perspective, to being in a farming community, to being in on top of a mountain. The bottom line is some of the things that are planned in an EMS system or with EMS rules as a whole are planned around more urban voices and mindsets. I'm not saying that's necessarily bad, but what's very interesting is this last week we were out doing labor and delivery training for a couple critical access hospitals that some of you are familiar with that are on the Eastern Plains. And the problem is that their labor and delivery units have shut down. They've shut down for a variety of reasons. Now, I also live in Pueblo, and even though Pueblo is not technically a rural area, we have some very rural problems. Our high-level NICU shut down several years ago for a couple reasons. One, staffing was part of the problem. Management was another one. But to be honest with you, one of the biggest strains economically to that was opiate-addicted babies. So these hospitals that we were visiting in the rural areas this last week and teaching and learning about what they're facing. Look, the public doesn't look at a hospital and say, you have these resources, I'm going there. What basically happens, as any human or human soul in an emergency will do, is that they gravitate towards an emergency room, a hospital, regardless of what its capability is. The public doesn't generally know that. So that doesn't change the fact that you have to deal with this in the moment. And that mindset is really important. And I'm sure some of you, and I'll let you enter this in, if you choose in the chat log. One of the challenges, I work in Walsenburg and Trinidad, and we have a critical access hospital that is attached to the state nursing home. And we see a lot of trauma. We see I-25. We have the second highest opiate addiction and death rate in the state. We're the second poorest county in the state. And this isn't something obviously that's on the welcome side. It's a beautiful community with a lot of hardworking people that has a lot of problems that are extended from lack of employment. The hospital is the biggest employer, ironically, now. And human trafficking and drug trafficking. And because we're closer to the border, all of those things play into a profile of those patients. So what's interesting to me is to see, having also worked in an urban area where we run 90,000 calls a year, it's very different mindset, very different skill set. And the hospital's mindsets are very different as well. So it's a very different level of competency. And what that means is, honestly, as basic providers, and I mean basic as a badge of pride, basic is everything we do. It doesn't matter if you're a medic or a doctor, it doesn't, because if you can't deal with the basic stuff, it doesn't matter. It really doesn't, because basic assessment, basic life-saving skills, those are the things that keep people going. And honestly, COVID showed a lot of this too, from an epidemiology standpoint and a pathophysiology standpoint. I'm going to say this in a way that I hope you can understand why I'm saying it this way. Literally, hospitals in areas were forced to grow up. And what I mean by that is that for many of those patients, because there was no other place for them to go, because hospitals were overrun, urban hospitals, right? So rural hospitals were forced to take on care at a different level than never seen before. And honestly, I don't think that was a bad thing. Now, people dying and suffering, that's not a good thing by any means. But the pandemic itself also showed not only the resiliency and the importance of BLS providers, but also the resiliency, and you can get through this if you look at the basic standpoint from a critical access hospital standpoint. So when you're thinking of that, it is more than just, from frontier to rural, is more than just a milepost. It's a mindset of, what am I going to do if? And I'll give you an example. So if you're starting out from a rural area and you're transporting somebody, say from a hospital, during an interfacility transfer or even a scene transfer to a hospital, it has to become part of your thinking, right? If the weather's bad or if this patient goes south, what are my options? Okay. So literally, where can I stop and possibly get help? Is there help? Or what am I going to do? And this is the other part I want to impart to you, is that for some things, and I'm speaking from my service and in Walsenburg more than anything, for many times, right, when the interstate's closed, the weather's bad, all of that, that hospital is the most stable place that they're going to be, honestly, because it's not like I can pull off the rest area and ask for help. We don't even have a rest area anymore. It's closed. So it's that thinking ahead. If I have a patient that's on the margin, what am I going to do if dot, dot, dot? That's very different than here in the Denver area with the urban counterparts, where they can get to somewhere very quickly within 10 minutes maybe, right? So just, that mindset starts, it's not just on top of a mountain, it's in your community, and it's more than just a milepost itself. And it includes things like farming and mining, and unfortunately in the news recently, we've had some very vivid examples of this. Wherever your community is, whether it's altitude, you don't think about that. Neither does a lot of visitors either when they bother to go to your area, right? So I'm not picking on Texas, but I am kind of picking on Texas. So they go up to a ski area, right? And it looks cool to ski, and then they have a couple, alcoholic beverages, and suddenly they don't feel well. And it's, to them, 2 hours is enough to acclimate, when the truth of the matter is it's 2 months to acclimate. Or working around a mine like I did in Nevada, where we had the exposure to cyanide and we had to be well aware of mining emergencies. I am not a rescue expert by any means, Farming and agriculture. Those of you in those areas also know. There's a, I don't even, and the people in those areas can let me know. They used to teach a silo class specifically for EMS. I think it was out of, maybe it was out of Akron or Holyoke. I can't remember. That was actually a really good class. It was one of the classes I took when I first came out there. And I hope they're still doing it because it is a very specialized form of understanding for those kinds of emergencies and how to get people out and be safe, the same way that a mining situation went. So it's distance, it's the industry that that place has, it's their mindset, it's also the socioeconomic things that drive that community. In many cases, it is that mine, it is that agricultural community. And right now, this statistic's about 3 years old, but about 53 million people roughly live in rural areas. Mostly the western states and populations. To give this as a benchmark for you, if you look at the trauma centers that are here in Colorado, right? Level one, we'll pick on level one, level two. I want you to think about this in context. Obviously, here at UC Anschutz, we're a level one. It's a teaching hospital. But when I speak about that, it's a regional facility. So what that means is regionally, they see people from all of the peripheral states. To give you a contextualization of that, MCR, or Medical Center of the Rockies in Levelland, is all now says a level one. That trauma center is the only trauma center at that level between there and Canada, if that helps if you're going north. So in the western states, how we deal with medicine is very different than the eastern. It's not necessarily wrong, it's just the resources. A little bit of the mindset are different too. There's certain differences, and even western slope versus eastern slope in Colorado. And part of this is how do you meet the needs of these resources? And the rural problems are beyond just EMS. The problem right now in places like Wyoming, Kansas, and unfortunately very soon here in Colorado, there are services that are disappearing. So if you call 911 in a couple places in Wyoming and Montana, nobody's coming. There isn't a service there. EMS is not a critical, deemed a critical service like fire and law enforcement. So what are your thoughts on that? What is your situations in your communities? Please jump in if you'd like to.
Well, Eve, you and I have known each other for many years, and yeah, EMS has always been the redheaded stepchild. We're not up there with the fire department.
Right.
We get in the metro area, and then EMS being part of fire is now considered essential service because it's fire-based.
Mm-hmm.
But when we're standalone, you are correct, it is no longer essential service, and we don't get the funding, we don't get the recognition, we don't get the support from the state that
Mm-hmm. That's true.
that fire and law enforcement do.
What do you think the biggest thing that could make change would be, Brian? If you could just pick one thing, and I know it's a difficult question because there's a lot of facets to it.
The change is going to have to be legislative.
Mhm.
It's going to be the legislature, whether it's the state level or whether it's at the federal level, recognizing emergency medicine as an essential service. And at which time it unfortunately is going to put more pressure on these small farming communities out here
Mhm.
on the Eastern Plains where I'm currently working. Uh, now we are going to be right there with law enforcement when it comes to funding.
Yes.
And where I'm at now, we are city supported, but just barely.
Yeah.
All we hear, especially this time of year when it's budget season, is how much the city's pumping into us to keep us afloat. And that if we're deemed an essential service, it's going to make it worse across the board. And I'm also familiar with Moffat County, I
Mhm.
spent time up in that northwest part of the state, and they went before the taxpayers here a couple years ago, and the taxpayers turned down uh, a taxation district, which would have been countywide, to fund EMS. And as a result, all of Moffett County is covered by a single ambulance or a couple of ambulances out of the town, out of the city of Craig.
Wow.
Where a one-way response may be an hour and a half if they have to go up to the dinosaur portion of the county.
That's a huge area too.
It is. And yeah, it's life and death. Somebody
Yeah.
has a heart attack west of Maybell,
Mhm.
the ambulance even to get to them is 30 minutes. Just
Under good circumstances.
under good circumstances,
Yeah.
yes. So yeah, I think I think it takes legislative action.
I agree with you at this point. Do you think that being in the area that you're at, where Brian works, they have community medicine. Do you think that's made a not necessarily a dent, but a difference in the perception of what EMS is?
I think so. Of course, as you know, I'm the community medic here, and um, yeah, folks in town know who I am. They
Mhm.
know I'm the one that goes out and sees their grandmother on a weekly basis and make sure she's taking her meds correctly and making sure that there aren't other issues starting to crop up that nobody's noticed. And so yes, I'm not just sitting here waiting for tones to drop.
Right.
I am seeing multiple patients daily, and with the idea of let's keep them from having to utilize 911. Let's prevent the ER visits if we can. And most people don't realize this. Most of us think that, hey, we take grandma to the hospital and the hospital bills Medicare or Medicaid and they get a
Mhm.
check. Not
Mhm.
the case.
Nope.
If grandma is seen in that ER for her diabetes and is seen again for complications of her diabetes within 30 days of the previous visit, Medicare and Medicaid do not pay the hospital for the second
Yeah.
or subsequent visits thereafter if they are recurring within 30 days of the previous visit.
Yeah, so there's an economic tie to that, and Brian, I agree. I think one of the bigger problems we have too is when we talk about Medicare and Medicaid is that there's some things that are automatic rejections from them. I mean, they don't even look at it; it's just like poof. And then at the same time, not every service has the resources to keep. The billing part of it is huge, but it's also a big part of cost too, and fiscally, it's the reason ER or hospitals are willing to do that and or tie into a community medic program. I think a lot of too is just one of the things that I will say that some bigger hospital systems are doing is that again, like Brian was saying from a regional standpoint, right? So I'll give you an example. The burn center here at Anschutz was undergoing a remodel. They're doing, and they just finished it. So when somebody is brought from a rural area to here, it goes beyond the patient's problem in the sense of um, family members have to travel here. They have to find a place to stay. The rehab process for that patient could be short, maybe a couple days, could be a couple weeks. And that economic toll is not only, the patient's bill, but it's what it takes out of the family because it's not cheap to do that. Plus the commuting, the loss of job time, all of that. So several areas are looking at, and this is also one of the bigger focuses, is it's one thing to bring somebody to a critical unit that you have a specialty unit you can't get anywhere else. Got that. So what do we do to turn around those beds quicker and get them back to their community critical access hospital when they are past that crisis? So that the family can be more involved in their care, that they can be doing PT and stuff like that. That's another element that's gaining a lot of traction because it's not something it's probably been done, but not quantified as an actual step to solving some of the rural healthcare crises, and yet it's providing support for those critical access hospitals. And this is the other thing. Most people in our business in a rural and frontier area don't realize until they need us, right? You call, we haul kind of thing. Well, I'm always struck by a lot of people move into the community where I work in Spanish Peaks because it's beautiful, okay, and it's very looks great to retire in. But then what happens when you have additional healthcare needs? Unfortunately, it could be cancer, it could be a lot of things. And then you do, as you get older, maybe need the system to find out that you might not get it when you call. And people don't look at houses and actually think about that. They're like, this is a great place for a house up a goat trail of a hill. And man, this is great. We're young and we're just getting retired. But then they don't think about what if, like power loss, water loss, all of those things, and how do you get resources or get somebody out of these places? I've come, the other part of that is also an education piece and that rapid treatment and response time. We haven't done as good of a job in EMS as we should in education, but I think now, like Brian alluded to, counties and rural frontier workforces are not sustainable in this form, right? It's a very unpopular time to try to pass a tax issue because, well, I got to be honest, those of you who had your property taxes assessed recently can probably say, wow, and I don't think that's going to change much. Even in rural areas, you get socked with property taxes that go up. There's only a finite amount of resources, and so how those are allocated, and how we ask for things, and people honestly don't volunteer anymore. That's hard. I've talked to a lot of fire departments that have tried running cadet programs, and there's programs that still attract people, but not at the level, and people don't necessarily volunteer or have an employer that supports a volunteer system. So these are all things that are hitting at the little trifecta, or if you will, tsunami of a lot of other events. And there's a lot of things. There's sparsely definitioned areas like frontier, which is, by the way, is more even isolated than rural, which, by the way, a lot of Colorado is considered frontier, where you're looking at distance and time and access to resources. The other big problem, quite honestly, they can't keep physicians. Physicians, and this is one of the reasons that the labor and delivery units are closing. It's a high risk anyway. It's one of the highest litigious professions because of the liability insurance. People in urban areas aren't going into it. But that's also an area where people may or may not be getting prenatal care. They may or may not be getting, access to anything, or literally, if they're migratory in the sense that their job takes them from, say, ranch to ranch or farm to farm, the less likely that is to be. And 1 in 5 people still is considered to be living in a rural setting. So when we start looking at the resources, and that's when they call us, right? These aren't necessarily strange rural cases. These are urban cases on rural steroids because it doesn't matter. Postpartum hemorrhage is postpartum hemorrhage, right? So whether it happens in Denver versus, say, Springfield, okay, not picking on a particular area, or frankly, even mine, it doesn't change the fact that you're going to have to deal with it. We don't get to say, man, we don't have any resources. Now, there's some exciting things that are happening in the state as well that are proactive. The question is, how do we bring it to that point? And the rural residents and the disproportionate amount of serious injuries and trauma, that's real for a variety of reasons. Also, risky enterprises like mining, like farming, like agriculture, like exposure. We're going to talk a little bit about zoonotic things as well, to high speed, high indices for motor vehicle accidents, right? And I will tell you, one of the most challenging places, and it was here in the rural 50 states, was Nevada. When I worked at Great Basin National Park, which is the most isolated park in the lower 48, we couldn't get helicopter support because there was no place for them to fuel. So they went to Salt Lake. If you had them by ground, that was a 6 hour, well, 4 hours to Salt Lake, 6 to Las Vegas in an ambulance, right? Then we get into gas and all this. Where do we get gas? I mean, it goes on and on and on. And so that was a challenge, right? Because there's no easy way to overcome even the logistics of supporting a service. So those kinds of things, those trauma injuries, I was always amazed at how many people hit each other on a straightaway with nothing around going 90 miles an hour. It's actually fascinating to some extent. But because of those high proportionate type accidents, that was also another problem. And stability and ability to think through, and how am I going to get this patient to the next resource, It may not be me flying them. It may be me driving maybe 2 hours to get to a resource, to get them flown out, or whatever the case may be. You guys are the definitive care, right? And the other issue with this, it's also a volume issue, which is the problem and can also be a bigger problem when you don't deal with it a lot. And so, obstetrics is, 90, you don't deliver the baby, she does, and 99% of the time it's fine until dot dot dot. So your exposure to that, your ability to train for that, the ability to stay up on best practice is really, really hard. And on top of it, we have a lot of well-intending medical directors, right, that are there. But it is still extraordinarily high proportion of medical directors that are voluntold or care about their community enough to volunteer, and they're general practitioners. I am not disrespecting general practitioners. I think they're amazing, but that expertise of EMS or frankly, emergency medicine, you can't do that. You can't. And what happens in a rural area, I can speak to our RETAC when, those of you who knew Dr. Weber, when Dr. Weber passed away, which was very sad and very somewhat sudden in the sense of healthy guy, right? Very generous guy, loved him to death. He had a huge area. And ultimately, over 1,200 providers at some point in time were under his medical direction. And he didn't do it because he got rich. He did it because he knew that they needed it. Well, when he was gone, now what? Right? So literally from services that have EMRs, because I have where I work, I have QRT teams or quick response teams that are EMRs. Yeah, who's going to do it, right? Whose hand's going to go up, and who's going to do it for $1,200 a year, which is actually the going rate's well above that. And how are they going to be involved? Does their hospital support them being involved? There's so many other issues. And literally in many towns, those family practitioners are doing it because they care about their community. They're not getting paid, and it's a lot for anybody to keep on. And now liabilities become even a bigger thing. So the shortage of specialties goes well beyond that. And there's no easy answer. Natural disasters or MCIs, you can have it. Train, right? Silo, mining accident. We had a bus accident right before Thanksgiving on an ice storm on I-25. It was a bus that was coming out of Chihuahua, Mexico, and literally everything that could go wrong did, besides the fact it was like a skating rink. The driver, we think, fell asleep. There was some bad injuries in there, but our biggest obstacle, quite honestly, when people went to the scene and tried to talk about doing start triage, right? Follow the sound of my voice. Well, that's great, but most of the folks on the bus didn't speak English. So they didn't know how to respond. And we didn't know how to respond. So it was very nice. This highway patrol was able to help us with that, but it was just, now what? Do we have a school bus? It was freezing cold. We had a lot of people that weren't hurt, but all of their stuff, their clothing and everything was either soaked in diesel or what, those kinds of things, right? How do you triage at a community center? How do you get I mean, all of those things. And it's hard even because even here, there's an MCI drill coming up in October here. Those of you who work with Pulsera, the whole intent of it is to do a surge on the hospital. And this is a busy ER. They see as many as 400 to 600 patients in a day, depending on how that works. Well, how do you handle a surge? Well, for my ER down there, a surge could be two, right? Especially at night. Could be the doc, maybe a nurse, but it's us. We're hospital based. So we transition from taking the patient in the field into there, which is a good experience. It's just another resource challenge. So what happens when you get another call or that crew is out on a transfer? Those kinds of things. And the distances are very difficult. And so, frankly, it's a liability. Also, equipment and every decision, although they talk about the paramedic, your decision as an EMS provider and how you allocate resources, man, that's challenging. I don't even know how some services pull it off. I've seen some extraordinarily creative things. How do we get a patient from here to there? I can't get the ambulance up there in a four-wheel drive. How do we get them out of there? Or the roads are too muddy, or there's a fire, there's a dust storm I mean, all of those things. this is a challenge. And if you have a rural dispatch system like we do too, that's not the only thing that they're doing. They're dispatching for fire, law enforcement, EMS, and probably taking every call into that municipality. So how do you tie in and get those resources when your communication system? Our biggest problem right now, I'll be very honest, our radio system is so old. Very shortly, Motorola will not support our handhelds anymore. We don't have any money. So how is this going to work? Because they were purchased on a grant from OEM and given to fire and law enforcement, but everything has a life cycle. So if you're not thinking about replacement costs, which I'm not dissing the person who got the grant, but it didn't enter their mind. How are we going to replace those? Those are our lifelines. And then when we had a big catastrophic wildland fire that burned both sides of the pass, it burned up the repeaters within about an hour. So there were, those kinds of things. And again, you can't drill for everything, but you can think about and talk about and think through things together, even on basic calls. How are we going to do this? Who's going to be there and how we're going to manage it? The volunteer basis we're talking about. And volunteering is tough because you have jobs, you have families. How do you sustain that? Some services pay stipends, some pay mileage, some don't pay anything. Some services became paid. That was one of the driving factors for us becoming paid. I'll be very honest, if we stayed the way we were, the county would have just dropped us back to volunteer. The reason the hospital took us over, which is not a bad motivation, but it's a very honest one, is they don't have anybody to do their IFTs. So they realize that a commercial service like AMR is not going to post a rig down there. And we do a lot of IFTs. Training and education and money, and they don't have the opportunity to practice skills a lot. There's some things you can do, and simulation is one of them. But right now, to be honest, I'm a lot of our folks want to try to go to the state conference, which is great, and work on cases, which we're going to get to here in a second. But they can't because, well, one, how do you backfill behind them? I don't have the staffing, and at the same time, the grant money for that is not very easy to get right now. And how we get medical direction. That depends on your community and your challenges. And those medical directors, please don't forget to thank those people, him or her. Um, Hopefully they're there, right? Or at least partially there. And they're not a milk carton medical director. Have you seen me lately? Kind of thing. Because remember, it's not a subservient relationship, it's a consumer relationship. You guys are it's taking care of people, especially in rural areas, a team sport. They are a critical part of the team. They have to be around the team as well. Air services, even if they are around, may or may not be staffed. That's been another problem. And again, part of this, there's the overuse of flight for a variety of reasons and patients' bill of rights. That's kind of why, Colorado's regulating or attempting to regulate the flight industry, and you don't always need a helicopter. There's some doctors that just do that. And it's like, well, then if right now, more so than ever, insurance companies are questioning why were they flown when they could have been driven. I mean, literally with Medicare, Medicaid, if I can stick Nana in a cab with a broken hip and she can still get there. If I don't have that specific language in my patient care report about why she needed a gurney, why she needed us, they'll kick it back. I guarantee it. Do you guys have any experience with air services that's improved, or have you also noticing that it's stretched kind of thin? Well, I can tell you our experience has been it's been stretched thin. They're not staffed a lot of the time, or they're out. Frankly, those resources are also stretched really thin. And your creative problem solving is really, really important. So when we talk about some of these cases, I want you to think about what are elements I need to think beyond that patient of what I need and don't need. Where am I going to get report out to? How am I, for us, it's actually astonishing too that, a lot of people depend on Google Maps, me included, but I can't do that in my area because probably two-thirds of our county, we don't have cell phone reception. By the way, Google Maps is wrong quite a bit. But at the same time, when we were bringing in some new people, I also realized now map reading skills is not something that's readily taught. And so, how do you show them how to use a map book, right? There's a bunch of things that have impacts on training as well. And you have to have some ingenuity and have that distance factor in the back of your mind and what resources you have, how much oxygen do you have, how are you going to keep this patient warm? By the way, that's a long way to go for somebody who's hurt, right? I mean, I can't tell you how bad our interstate is. It's pretty bad. And I can guarantee we're going to hit every pothole. So even how I can alleviate pain or make that transport easier could be the type of cot mattress. We've actually modified it for transfers now, where we change it out and we allow that patient a little bit more comfortability because you're on a giant ironing board with wheels. Vacuum mattresses work great if you can pack around them. Those kinds of things. My patient may need a bunch of things that I haven't even thought about, and sometimes that's distracting stuff. Like maybe one patient we had, we tried audiobooks with. I mean, those kinds of things and those kinds of distances also make a difference. All right. So we talked about rural hospitals not only having a staff all the time, that's a big thing. And when do you bypass, when do you not? Do you have a bypass policy? What does it mean when you bring somebody, because a lot of the rural hospitals have a helipad. So you bring your patient to the helipad intercepting a helicopter. What's considered an EMTALA violation? Well, if that patient crosses that ER breach, yes. But if you're going there because of the helispot and it being lit and being safe, no, that's not necessarily an EMTALA violation. Actually, there's a lot of things that were perceptually perceived as one that are actually not. So it's really important to understand your rules. Have those conversations with your hospital as well. Don't wait until you have that patient. One of the reasons that, and we have some physicians, I'll just leave the names out of it, but the personalities where they're like, I can't believe you didn't bring them here because of blah, blah, blah. Well, no, I didn't because I knew that they were going to end up getting flown out. So I'm kind of eliminating the middleman. And if I'm on that side of the county, then yes, I'm going to have them land at the football field or I'm going to have them land at our helipad. And it's not saying anything that your care is bad, but we also have control over that decision. It's control not in the sense of it's me being in control, it's in the sense of being an advocate for that patient and what is the best circumstances. And that's sometimes a very hard call. Do I take them there and hope they get stabilized? In I'll say our mid-county point, you kind of have to think through that. If we're on one side of the wet mountains, I got to start thinking about where am I going to go? And it could be actually towards Raton, which is out of the state, and that gets into a whole other issue. All right, so let's take a look at some of this. One of the bigger explosive issues in rural America has been drugs, and the contributing factors are a wide variety. I just told you have a huge opiate problem, partially because we are on an interstate system or close to it, truck stops. There's a whole profiling thing that's really kind of fascinating that the DEA also has put out as training where you're looking at truck stops are your friend and your enemy at the same time. If you've never had an opportunity to listen to human trafficking in Colorado and the traits of, believe it or not, Johnson's Corner on I-25, the famous cinnamon rolls, and now the diner is now a Black Bear Diner, was one of the highest access points for human trafficking in the state of Colorado. Would never have guessed that. And as rural providers, we don't think about that, but actually, you probably have been in contact with it and not known it. It is a very eye-opening look at what are the signs of that. And it doesn't have to necessarily even be a sex industry kind of thing. It could be agricultural exploitation. It could be excuse me, it could be culinary. There's all kinds of things that you don't think about. Denver Health actually has two providers. One of them is their SANE educator, their sexual assault educator, who comes out, who was also freed herself from trafficking. She was part of it, and then brings up all of these profiling statistics about what to look for. And I have to tell you, I'd recommend it to any law enforcement, EMS, or fire person or ER person. Okay, so the new reality, opiate struggles, just really quickly on this documentary, is just really quick. Do you have any Labor Day sales? Sorry, I'm gonna skip in just a second. I'm cheap. I didn't pay for the. There we go.
I've got possible overdose. There's some stuff sitting on the table there. Can you wake up for me? I think the best definition of addiction that I've ever heard is an irresistible urge to perform an irrational act. Irresistible urge to perform an irrational act.
Over 2 decades ago, painkillers derived from synthetic morphine were seen as a miracle drug for patients coping with chronic pain. Since then, numerous forms of synthesized narcotics have made their way into doctors' offices and pharmacies. According to the Centers for Disease Control, as the number of opioids increased, so did addiction rates. The Trump administration has declared the problem a public health emergency.
They hit people with suits, dresses, indiscriminate. But because the perception of risk were down, it was like inviting the drug dealer to your child's birthday party. You know, they were just handing them out because it was supposed to be thought of as a good thing.
In 2015, the CDC reported over 33,000 deaths nationwide related to opioid overdose. Over the past 2 years, that number has more than doubled.
Last year, we lost over 64,000 people in America. That's more fatalities than the average number of servicemen lost during World War II. So if somebody does not want to call this a war, I don't know where you get 64,000 Americans dying from heroin and opioid overdoses. Not ever be a problem.
Look up for me, dear. Those developing the strategies to fight opioid misuse are fighting a war on 2 fronts. One is availability. Officials with the Iowa Governor's Office of Drug Control Policy are concerned medicines like Percocet, Oxycontin, and other fentanyls have a safer persona than illicit drugs. Komendowski believes that safer persona creates a climate for addiction. The other front is the amount. Federal government officials contend with the perception of low risk. Opioids have been prescribed in ample amounts with little concern for misuse. Making physicians aware of how many pills are being written into prescriptions is one way opioid misuse is being confronted.
Previously, you'd see a prescription come in maybe for 60 tablets. Now we're seeing more prescriptions written for 30.
As a licensed pharmacist
Bring that with you, though. Okay.
and legislator in the Iowa House of Representatives, John Forbes uses his unique position to help craft legislation aimed at helping curb opioid misuse in rural Iowa. But Forbes knows he and his colleagues on the other side of the pharmacy counter are on the front lines of fighting the epidemic.
Pharmacists just need to be vigilant whenever they have a prescription presented to them that they have questions about.
A tool pharmacists use when a suspicious prescription comes to their attention is the Prescription Drug Monitoring Program. Established in the 1930s to track Schedule II narcotics, the program has evolved to an electronic database stretching coast to coast.
We check that database on new prescriptions, especially patients that are new to our pharmacy, to make sure they're not doctor shopping or going to multiple pharmacies to try to obtain controlled substances.
Last year, the Drug Enforcement Administration stepped in to help slow the opioid epidemic by allowing pharmacies to partially fill prescriptions.
A program like this helps keep larger quantities of opioids out of the system, so there's less chance for diversion.
Let's go ahead and give that Narcan. Narcan. A life-saving drug helping addicts who have overdosed is a medication called naloxone or Narcan. This product can bring someone out of an overdose in minutes, but it also has a high price tag.
Narcan going in at $15.07.
One dose can cost up to $100, which can strain small-town budgets. And it comes with one important caveat.
It's an opportunity to treat and care for somebody, to intervene. It's not a cure. And that's the biggest misconception we see with naloxone.
One place that treatment and care can be found stretches over a 7-county area in north central Iowa. Prairie Ridge Integrated Behavioral Health Care in Mason City. It's a treatment center exploring new ways to help people cope with addiction, combining mental and physical health services with recovery treatment. The center uses state-of-the-art technology and strong doses of compassion to help shrink misuse disorders in rural Iowa.
That's something we have to keep working on, is to make substance use and mental health treatment part of our healthcare system, not something that's viewed by the public as a weakness or a moral failing. It's a biochemical brain disease, and it's really time that we focus on that as opposed to an act of willpower or lack thereof.
And when the consequences hit American culture anywhere, low population, rural areas where the density is low, they have the least amount of healthcare, the least amount of counseling, the least amount of resources for public safety. They're at risk for much longer than where we can apply all the big money and resources.
Hey, their name. Officials in the Hawkeye State see a long fight ahead that will require a balance between limited funding and scarce resources. They also believe to win the war will demand an increased respect for the medicines being prescribed. For Market to Market, I'm John Torby.
Okay, so the interesting part of this as well is, besides the obvious issue with the opiate epidemic, is that the issue of mental health. And for our community, I have to be very honest, if I have somebody who's coming and calling because of suicidal ideations, or possibly, they're looking to get treatment for whatever it is, methamphetamine or opiate or alcohol or whatever, I literally, my heart sinks a little bit, because I know what our system is down there, and we don't have one. And the problem is that we're missing a lot of things. Almost all of us are missing mental health components. Now we have a telemed thing for counseling and stuff like that. And when it works, and I think it could for some, but not for all, if they need a treatment bed or they need to get to somewhere, that's a whole other issue. And it has come back to us, in the sense our hospital is being sued actually over something like this. I don't have an answer. We're not near a Denver metropolitan area. And frankly, even if you are in a metropolitan area, if you're seeking psychiatric help, it is very difficult to find any bed, actually, or if you don't have insurance, it's worse. So this kind of ties in also with, as we lose resources, in addition to psychiatric resources, again, which are undervalued, it's also obstetrical and pediatric that are disappearing because of the lack of fiscal resources to support them. Oh, and just one other side note with the opiate stuff. We actually, this will be interesting for us. We're getting, the truck stop too is also getting, we have two of them. They're getting an Narcan dispensing machine. This will be interesting because it's funded. The nasal Narcan is funded. Anybody can access it. I will tell you, we've had problems with people trying to steal it off our bags and out of our trucks, because of the abuse being so high there, that they know we have it and they will steal it to take it to wherever. I'm curious. We haven't started this yet. It's supposed to start in the spring of next year, and I'll just be curious to see what kind of impact it has. It's a new approach, and not saying it's a bad approach. I'm not saying it's a good approach. It's just a new approach. And they're putting the vending machine in the outside the jail area, and then also by the truck stop itself. That'll be kind of interesting. And one of the truck stops tends to have more incidents of this problem than others. Okay, so let's take a look at some obstetrical and pediatric things. Critical access hospitals we talk about are not delivering babies, but let's take a look at, as they're delivering them because they still show up. You can't just send a mom out of there. So just a couple things for food for thought. Postpartum hemorrhage. When we talk about the Blood Project here in Colorado, a lot of people were initially thinking, oh, it's going to be trauma, that it makes a difference. Well, it does. But ironically, the recipients of the blood that have been saved or greatly supported by access to blood in these rural areas have been GI bleeds and postpartum hemorrhages. Postpartum hemorrhage causes, it's still a high percentage, even in the Western countries like ours, 25% of annual deaths. It can be following a cesarean, it can be following a normal birth, and it's also with certain attributes possibly lacking prenatal care. Mnemonic to use are the four T's: tone, trauma, tissue, and thrombin, meaning coagulopathy, or the ability for blood to clot. So this was one of our patients. She's a 32-year-old female who'd been home for 4 days. She delivered the baby at home, an 8-pound, 10-ounce baby, kind of a bigger baby. She's been active at home and noticed that she had some bleeding. The bleeding persistently got worse over the 3 days, and she got up to feed the baby. Some point in the night, she fell on the floor and her husband found her on the floor, and that's when they were called. She presents with cool, clammy skin, blood pressure that's low. Her map's probably pretty icky. Pulse is 130, respiratory rate's 24, and she's and meditating normally. Now, a couple things, right? We know about the baby at this point. Um, it's nighttime at a hospital that has one ER doc and one maybe access to a doc on the phone. But is she showing concerning signs of hypovolemia? Yep. That pulse, she's tachycardic. That gas pedal is stuck to the ground. She's breathing. She's fainted. She became hypovolemic enough that she actually fell over because her squash wasn't getting enough oxygen. So the weighing decision for this particular rural crew is, do we go to our critical access hospital or do we take her to a center, or at least a hospital that has labor and delivery capabilities where they can actually potentially surgically intervene in the problem? Okay, so think about that. Think about your own hospital. Think about how she's presenting and your distances. What are your options? So, kind of in your mind, right? You're being that MacGyver. You're thinking of all these resources and ideas about what could go wrong and what can go right. So what are we doing? We're asking, what are our capabilities? What are the ambulance's capabilities? Where do I take them? Does this warrant a different form of transportation? Does this warrant flight? Maybe, maybe not. Um, she gave birth at home, so she may not have a medical provider at that hospital, even if they do have an L&D unit. She would be a good candidate for blood, I can tell you that. And she's probably bleeding internally, which is another problem because otherwise it would have been addressed sooner. So think about your community, think about who's with you. What would you do?
One
Obviously,
thing
go
flight-
ahead. Go ahead.
One thing flights could do is they can bring blood with them.
They
Where,
can. Kevin, what do you have to tell them?
but you have to tell them what type of blood they got, hopefully if they know, and then, what the situation is. And then the other thing that we fight with that is the compatibility, you know.
Yep. Well, it's interesting too because the human donor part, the live donor part, is a new facet to the blood program as well. Yeah, and you're right. And by the way, yes, if you think you're going to be using it, and frankly, even ground critical care, if they know and have access to it, they will bring it. But you have to make sure, and I'll just say this from our hospital's perspective, I'm not bashing anybody particularly. It's just when you're talking, right, and we're busy because we're taking care of a sick patient, make sure you're very specific. We now have a checklist that the unit coordinator uses because they're the ones that are primarily on the phone, and getting that patient hooked up and questions that they need to ask us and that kind of thing so they can let that service know this is what they're getting into. But yeah, there's a lot of going ons here, and you're right. Maybe they can bring it, maybe they can't. And we talked about the four T's. So uterine tone or lack thereof can also be a compromising factor. I always thought this was fascinating. In labor and delivery, they tell you if she loses 500 cc's or more, it's considered critical. Yeah, but how are you going to tell? If you've been around a delivery with all the fluid and everything else, you're going to look at her vital signs. You're going to look at her. She's going to tell you. It does happen more frequently than you think. It happens in 1 in 20 deliveries. If they have prolonged labor, if the kid's big, if they have a newborn who's greater than 8.5, which this one was, if they're older, which by the way, advanced maternal age is 35 and older, those are all things that are risk factors. And you don't get to weigh those, but you're going to find out about them right when you're doing your assessment of your patient. And it's usually caused by uterine, cervical, or perineal or vaginal lacerations that occur during the birth. The difference is at a home birth, they probably didn't catch it or know it happened. Okay. Or maybe the placenta retained tissue. That's why it's important they get a look at that placenta so they can see if it's intact. Is it shiny? Is it gray? Is it super veiny? There's certain things that they look for, that also would increase the chance they may have to go look at her to make sure there's not a tear or missing piece. Okay. An invasive placenta is the most common cause at about 533 pregnancies, once in 533. That's not low. Have excessive blood loss, right? And time is going to be of the essence here. Another one that springs to mind, and unfortunately happened recently, was with farms and silos. This was the most recent one in Keensburg. This was at a manure pit, at a dairy farm. And those of you who are in the area probably know more about it. It obviously hit the news because of the unfortunately 6 people lost their lives. And what I've read, and please correct me if you know differently, it was an accident in the fact that one person accidentally released the toxic gas. Does that sound correct? Okay, it sounds like most of you probably have either heard what I have or not. And again, we don't think of the farming industry or that side of it as being dangerous, but they're inside a grain silo, also in a manure pit at some of these larger feedlots. There's buildup of toxic gases. Silo rescue is a very specialized form of rescue. The dust from there, silos can also get a toxic buildup where they can actually explode. And it's not something you just run in there and jump in. The one that I was inferring from Keensburg that happened recently, I believe it was all methane from the cow manure. If that's not correct, please jump in. And they went in to help him, and apparently it cascaded and got worse from there, hence why 6 people died. It is a source of things that we don't think about. And silo rescue and farm safety is a whole separate aspect of actual emergency medicine.
I think it's gonna get worse before it gets better. You guys are gonna count me down and tell me what's gonna happen here?
Surprise.
Okay, as ready as I'm gonna be. Like an incident. I can't move my legs at all. And you guys are making it worse. I can't move, so yeah, I am definitely trapped. So much. You're gonna hear some serious screaming in the background. Let's expect.
We're getting up. Gonna do things the wrong way here. See that up to point of the bell and the dragons, okay? How are you saying for the time today? Your age. On that. He's just gonna jump in.
And
Did you feel?
yeah, he definitely put more pressure on me when he jumped in. Like, more trapped. I did not feel Jade get in here. Yeah. The right way. Yeah, that's definitely like pushing all the grain into my legs. Nothing that's around me. Close my hair. Okay. So the same thing. Like, this is a-
I'm gonna hand you two.
one part of it.
Recorded.
I know. I Right up, right up.
Oops, sorry about that. So what you're seeing is something, if you've not been around this before, that is obviously a problem. Let me get this back here. Sorry about that. Is the fact that the weight, the dust, you hear a comment about the dust, all of that is really toxic. And the other thing that I learned when I took that class, I didn't realize is that when people get in there as well, it shifts the weight. She can't move. She's not kidding. And that's and the other part of this in some silos, and again, those of you who work around them more, there's augers in them as well. So also falling into the auger is another part of what you would see. Okay, so they were talking about the toxic gas exposure, and in this case, the coroner's office said that all of them died of result of confined space rescue, which is this whole other element. And whether the gas is from the grain or the gas is from the manure, they're obviously pending autopsies. But the three biggest reasons that people get hurt in the farming industry are falls from heights, overcome by oxygen or oxygen depleting fumes or dust in confined spaces. And actually, when I was doing some of these case research, augers were a pretty big source of that. We've all sat through those chapters on how to turn off farming equipment, but to be honest with you, unless you absolutely know what you're doing, and having worked at a school that made John Deere tractors with the students, I didn't appreciate how sophisticated some of these things were. And actually, it's complicated. It really is. Okay, so when we're talking about, the confined space rescue and the emergencies around it, the gas can also be explosive. And this also includes fertilizer tanks, storage bins. There's a lot of things. Mining's not that much different. I was much more familiar with dealing with mines and cyanide and some of the other stuff. But these are dangerous professions. Even, working around slag piles. Unfortunately, there's been a few deaths at one of the mines that I work near, up near Cripple Creek, where slag piles had collapsed in, much like a grain rescue. Okay. So these guys under OSHA have different requirements and specialty teams, but again, it's a very specialized form of rescue. And it's unfortunately one that if you don't know what you're doing as a volunteer or even just as a pay provider and not understanding what you're getting into, you're exposing yourself to this, which includes nitrogen gas, carbon dioxide, and methane. High angles, confined spaces, there's a whole different recipe for getting people in and out of there. And again, an old silo looks harmless. I mean, personally, as a kid, this would look like a great place to be and play, but there's still a source of a lot of injury. And also, even in the mining areas, the mining recap program that MSHA's had for, oh gosh, for 20 years, in these rural areas where they're capping off entrances to mines, Inevitably, you have to imagine, in addition to the not only the shaft access point with the hole or the door, there's hundreds and hundreds of air shafts. And I've been on several of those. When I lived in Central City up near Netherland in that area, we would get people all the time that had been either hiking or out, even mountain biking or dirt bike riding. And a lot of these mines are not necessarily known or marked. Now they've tried through a lot of initiatives to mark and cap off things, but again, it's easy to miss. And some of these older mines that were never documented are another problem. Another aspect that we don't think of in and follow me on this, is zoonotic or exposure to things around agriculture or animals. So we're talking about things like Zika, tularemia, Lyme disease, West Nile, bubonic plague. All of those are here. You don't think about that until you're exposed or see somebody around it. When I worked at the Grand Canyon, we had a researcher who went out and was going out for 10 days and back for 4, who did research with mountain lions. And when a collar goes dead, meaning it stops moving, it's either because the animal has died or the collar has fallen off or it's ended its lifespan. So this particular collar went dead, so they were out there for the 10 days looking for it. Well, it was a female lion that apparently had contracted plague, which, by the way, is here in the western US. It is around you in prairie dog colonies. Any small mammal colony can have it. And he had the fleas jump on him. And because he was not somebody we saw frequently, because he was out for 10 days, came back for 4, he's not a guy that had a team around him. He was a researcher who did a lot of solo stuff. He came home, wasn't feeling well, and actually died of the plague and was dead before we found him in his cabin there. Bubonic plague, tularemia, Lyme disease, these are all things that are found here in our area, right? Rabies, that kind of thing. Zoonotic disease got a pretty big focus when we were talking about the origins of COVID and where it may not have come from or come from, depending on which part you read. But also, part of this is coming in contact with animals. Zoonotic diseases can be spread from the animal to human, not always human to human, but animal to person. And so, this is another thing that we see, especially in taxidermy with untreated hides. One thing I left off here was anthrax. So we see cases. West Nile's become a big one this year because it's been humid, hot, and rainy. My county has a lot of it. Any county that has livestock. So this happened to be a patient who ended up in our hospital and was transported to another facility. He was a 50-year-old, or sorry, 56-year-old Hispanic man. He used to smoke. He was basically out working in the fields and started developing a low-grade fever and fatigue, and he wasn't getting any better. So he came into the critical access hospital and was getting progressively more and more ill. So they couldn't isolate it. Now, one thing about zoonotic issues, and by the way, another big one that's hit the news recently is hantavirus. Hantavirus is what they believe killed Gene Hackman's wife, and it was actually discovered in New Mexico, but it's anywhere where there's deer mice. So if you have a huge accumulation of droppings and you're in there sweeping and not wearing respiratory protection or basically not spraying it with bleach to keep the dust down, you're at high risk for it. My guess is they were in the house or in the garage and she came in contact with it. She thought it was COVID, but these patients will develop acute pulmonary edema. So in this case, this gentleman came in, was not feeling well. They did blood cultures, but you have to understand when they do lab tests for this kind of thing, they're looking for general stuff, right? There's some of this that has to be specialized stuff that they don't, you have to actually ask for. It's kind of like when you do a drug test, right? A drug screen looks for a 10-panel drug screen looks for 10 things that it might be, but those are the most common. So the blood tests were coming up negative, but he wasn't getting any better. He had no real pertinent history except for his smoking, but he had quit before. He had a really bad headache. He became febrile. He became very short of breath. Dyspnea set in, and his chest X-ray started looking worse and worse. So where is this coming from, right? What were you doing? And literally before he was transferred out, because at that point he was very ill, everything they were trying was not working. So literally one night before he was on the ventilator, they were sitting there and asking him questions. Tell me everything you did. Were you out tilling a field? Were you out working with the livestock? Well, literally what happened was he went, well, no, I didn't do anything unusual. My son went hunting with me. That perked up the nurse's attention because she started thinking, okay, so what were you hunting? As it turns out, they were hunting rabbits, and it's not an Elmer Fudd thing. They were hunting rabbits, and he was skinning them, and he got exposed to tularemia. Every now and then in Colorado, too, you'll see posters about please don't pick up dead rabbits, don't let your dogs get near them because they have tularemia. Or if you see a rabbit that doesn't make sense of how it died, they will do a necropsy and look for it. Well, in this case, that's absolutely what he had. He had, basically been exposed to tularemia. Now, there was some speculation he also could have gotten it from the sewage that he was working around in that area. That's possible too. Probably the more prevailing thing was the actual rabbit. And what happened was this would not have happened if she hadn't done a really in-depth history and dug even deeper because the standard questioning didn't cover this. And that's the challenge with rural patients. You have to think about, obviously, if you ask somebody here, hey, have you been out hunting rabbits? Well, if they answered that in the Denver area, you probably think they're nuts, which maybe they are. But he developed a lot of complications from the rabbit fever that led to pulmonary edema and unfortunately his demise. He became pneumoseptic and he passed away. Tularemia is around, ticks, deer flies. It's in all of the western states. It's throughout the western US, actually. There's only a few places that it's not found because it's not warm enough long enough. That would be some of the states towards the Great Lakes area and up into Canada. And remember, recreational emergencies, ATVs, tractors, I wouldn't have known this until I worked in an area where there's a lot of corn. How many accidents happen in areas where there's corn and people can't see on the roads, slowing down? All of these things play into that. Boating accidents, fishing accidents, hunting accidents, learning how to deal with environmental emergencies. That too is part of rural frontier medicine. And it does weigh into you. I've been the longest I've ever been with a patient on a rescue is almost 40 hours on the side of a hill on a scree slope. He went up there, was unprepared, fell down the slope on the ice, and it took us that long to get him off the hill. Well, I say hill, it's actually a mountain. A couple things, right? Your safety's first. It's not safe to carry him down. It's not safe to move him. It's not safe to get heli support up there. So we had to address some things. Yeah, I knew he had a broken hip. I absolutely knew that. But for 40 plus hours, not only managing his pain, but he had nutritional needs. I had to keep him warm. He had to eat, those kinds of things. How do I manage that, right? That's out of what you normally would see in a typical EMS setting. Remember, you guys have lengthy transports, long transports. It's more than just the milepost. You don't have a lot of opportunities to maintain your skills or have access to them. Frequent training, being involved, doing preventative stuff. And I don't have an answer to solve the access problem that we all face. We have a huge gap in healthcare that isn't getting any better. And the question is, what do we do and what's on the horizon for us? Well, that's a tough one because we don't have all the answers. We don't have the ability to fix some of these things. And at the same time, services are disappearing. The good news is that people like yourselves that work in these areas are obviously innovative, have to think above. And I'm an optimist, maybe too much so, that I think some of these are not insurmountable, but it does mean working together. The other part of that, yeah, and I see that some of you added some stuff to the comments. I just saw the comment about the five warning, not ignoring the warning signs. So all of these things, that you don't see and aren't in a textbook, rely on your spidey senses. If it seems stupid, don't do it. If it seems like there's something else to it, ask questions. If you don't know, ask. And the biggest thing that you have is that resiliency, that ability to, for lack of a better word, to MacGyver and also look at everything that's around you and figure out what you can do. And then how do I get to the next point? How do I safely get a patient to the next point? Sometimes that may be that they have to stay where they're at. That's okay. Make sure you're thinking and advocating for them first and foremost. Be interested in what Colorado's doing, the Blood Project, how we're going to fund rural services. Part of the ground ambulance certification process is looking at that as well. Have a voice. Even if you don't feel like you have something to offer, you do. You have your perspective. You have your life experiences and your opinions, and they do matter. Even if you don't want to participate in the meeting, just listen to it or be informed, because that voice is really, really important. What's perceived in the Denver area is different than what you perceive. The consequences of some of these decisions may not affect an urban service, but they might affect yours. So again, consider all of that when you're thinking about what can I do differently? How can I support my service? How can I interact with the services that are around me and make things better for everybody? That's an important thing. And don't forget the power of you. That's also a very important thing.